So now we can roll into some more toxicology. So I'm going to be talking about some pearls of pediatric toxicology. And those of you who already know me know that pediatrics is one of my favorite areas of emergency medicine. And so I have a lecture just covering some kind of critical areas that come up a lot in pediatrics. So I'm going to talk about one pill killers. So these are things that we worry about in a single dose that might potentially be lethal to a child. We'll talk about non-toxic ingestions. So a lot of times kids come in after an ingestion and maybe it's something that we don't have to worry about at all. And a lot of these are things that maybe they don't even have to be referred to the ER. And that's probably not a decision you're going to make when you're on the phone with the parent, but poison control can make that kind of recommendation to keep a kid at home. So we'll talk about that. And then a few common household hazards. So this is an article that was in the Daily News, I think, during my fellowship. One of my co-fellows actually had this case, child that was exposed to literally one pill, one of grandma's pills. And in this case, the answer to that question said it was extended release was enough to kill this child. So when we talk about one pill killers, I'm going to be talking here about pharmaceutical products. So not recreational products, not kind of household chemicals that are used. So specifically, we're talking about drugs that are used medically, where one single pill is potentially a lethal dose in a child, or if it's a liquid medication, a single sip. So anyone have some ideas about what kind of classes of medications that we're worried about? Sulfonylureas, great. What is, I didn't hear that. TCAs, potentially. Usually not by the oral route. Calcium channel blockers, great. Did someone say methadone? Yeah, absolutely. So opioids, particularly long-acting opioids, we worry about. All right, there's actually a few more on the list. So some of these are not fitting our typical paradigm of what we think of when we say one pill killers, in terms of it doesn't matter what they look like when we see them in the ER, they need to be admitted. And I'll talk about how this list narrows down when you're looking for those things. So things that we worry about potentially, though, after one pill, some antihistamines potentially, benzocaine, bupropion, camphor, clonidine, diphenoxylate atropine, that's Lomotil, monoamine oxidase inhibitors, something we don't see very often, but potentially really dangerous, methyl salicylate or oil of wintergreen, opioids, sulfonylureas, and sustained release beta blockers and calcium channel blockers, and then TCAs. So the question is, does any of these patients who takes, potentially found with one of these tablets that could be in the child need to be admitted? And how do we decide which of these patients need to be admitted? Okay, so yeah, if they're showing signs of symptoms of poisoning, then definitely we're worried about them. The dose, well, one tablet of any of these is potentially enough, depending on the size of the child, to harm them. Okay, so we're getting closer. The pharmacokinetics definitely play a role, and it's not so much necessarily how long the symptoms last, although that is important, but really do they have potential for delayed onset of symptoms, right? So the question is, we see a kid, they look great, they're found with an open bottle of grandma's pills. You don't know whether they took one or not. And, is this something that you have to worry about, even if they look okay after a reasonable period of observation in the ER, right? So it should be deadly in a dose. It should have delayed onset of toxicity. And then there's always this question of ingestion versus exposure. And that's part of what confuses a lot of the literature. So ingestion is the child swallowed a pill. Right. Exposure is child is found next to pills and we don't know for sure whether they took one or not. And it's often kind of conflated in the literature. Obviously, if they didn't take it being found with it isn't enough to harm them, but you can't really necessarily sort that out. So you have to kind of assume, if you don't know otherwise, that there is a tablet in that child. And so the things that potentially are deadly and have delayed onset of toxicity are the ones that, even if they look okay, they need to be admitted, because maybe they took it, maybe they didn't, but you can't rely on the fact that the kid looks good to be able to safely send them home. Right. So when we start to take out the things that have rapid onset of toxicity, it's a lot shorter list. Right. So some of the antihistamines can be delayed because they have delayed gastric emptying and delayed absorption potentially. Bupropion is commonly delayed. The opioids, including Lomotil, monoamine oxidase inhibitors, sulfonylureas, and the beta blockers and calcium channel blockers. So a lot shorter list. Most of these things, or a lot of these things at least, are more commonly associated with rapid onset of toxicity. We have particularly good data for the sulfonylureas that this study in 1996, that was a retrospective evaluation of sulfonylurea ingestions. And most kids had some early onset of hypoglycemia after ingestion of a sulfonylurea, but some patients who initially had euglycemia developed hypoglycemia in a delayed fashion, sometimes as late as 21 hours post-ingestion. So there's no reasonable period of observation in the ED where you're going to be able to safely say they can go home if there's the potential that they took a tablet of a sulfonylurea. And one tablet was enough to cause it in this study. Now, some will say that maybe this isn't necessarily applicable now, because there were different sulfonylureas that were in common use then that are no longer used, and it's not clear how many of those were those older sulfonylureas. But I think the cautious approach is to assume that this is still the case now. There's one other thing I want to point out about this article, that especially when you rotate at the Poison Center, just kind of philosophically in terms of how we approach these, it has a word that you really shouldn't use when we're talking about pediatric toxicology, and particularly small kids with ingestions that were not intended for self-harm. You can say this kid accidentally swallowed this blood pressure medicine. And, philosophically, there are no accidental pediatric ingestions, right? Because that is saying it's kind of like an act of God. It's something that just happened. But every single one of these, we should have the mindset is inherently preventable, right? This should never happen. And when we have, anytime that there's a kid with an ingestion, you have to take the mindset that this is something that should have been prevented. It could have been prevented. And that if a good education of the parent about preventing access to these types of medications for children will prevent these kinds of things from happening. So don't use the word accidental. You make toxicologists mad. So there's another thing to take from this case, that this was grandma's tablet, and grandparents are an independent risk factor for pediatric poisoning. And why is that? Well, because grandma has her pocketbook, and that's where she keeps her medication. And that's also where she keeps the candy that she hands out to the children. So the kids are going to go looking for that candy that they remember coming from that pocketbook. And also the medications are in there. So just a simple intervention of just telling the grandparent or whoever has potentially dangerous medications in their bag. First of all, don't carry it in things that aren't child safe. But second, if you come into the household where there's small children, hang up the pocketbook. Don't just put it down on the couch or someplace that a kid could get to it. And when cases come into poison control, one of the roles of poison centers is, a lot of times for pediatric cases, the kids wind up being just fine. But every time those cases get called into poison control, and even when they're called in from the home in particular, that they send information to the household about poison proofing their home and preventing, hopefully, the next time that it's going to be more consequential. So now let's talk about some non-toxic ingestions. And everybody know who Paracelsus is? Kind of the father of toxicology. He said, what is there that is not a poison? All things are poison and nothing is without a poison. It is only the dose that makes a thing not a poison, right? So this is kind of the concept of the dose response curve. Everything in the world has potential toxicity, even things that are essential for life, right? Like if you have enough water, you're going to get hyponatremia and seizures. If you have enough oxygen, you're going to have damage to your lungs from that extra oxygen. So, every single thing in the world is potentially harmful. So what does it even mean to say that something is non-toxic? Well, there are some things that have predictable, that we mean that they're going to be non-toxic in a dose that a child is reasonably going to be exposed to. And I'm going to try to kind of flush that out, what the parameters are that for something that we can safely feel comfortable that this is a non-toxic, that we don't expect any significant bad outcome for a child after exposure to a specific type of product. So give you a case, it's 3 a.m. Pediatric ED receives a call from a worried mother about her 3-year-old boy who's found playing with an open container of glue. The mother says she can see some glue in and around the child's mouth. You can see from my dated references how long ago this was that I first made this. And the boy is alert, playful, interactive, and without complaints. And she identifies the product. It's called Elmer's Glue All. She says it's a 4-ounce container and there's maybe an ounce of it missing. She's not sure how much there was before the kid was playing with it, if it's a new bottle or not. But there's no other products found near the child. She says that it's non-toxic, that it was manufactured in 2002 by Elmer's Products, and it doesn't have the word caution, warning, or danger on it. Question is, what do you do, right? Do you bring the kid to the ER to be admitted? Do you bring the kid to the ER to be evaluated? Do you bring the child to the pediatrician the next morning to be evaluated? Observe the child at home? We're not going to shoot the hostage. So who says A? I'd be very cautious, but okay. Who says B? I'm surprised. I think most people feel very uncomfortable giving advice over the phone so that you don't have to bring them in. I think even me, as somebody who's very comfortable with toxicology, when I get a call from home in the ER, I'm going to say, if you're concerned about your child, bring them in and we'll evaluate them. So what about observing the child at home? I think that's very reasonable. And I can tell you that if this case was called into poison control from the home before, rather than just bringing them and the patients in front of you, that they're going to tell this parent to keep this kid at home. And that's, again, an important role of poison centers in that they prevent unnecessary ER visits and unnecessary admissions. And this is a case that a lot of doctors are uncomfortable managing over the phone, but the C-SPIs, the people who answered the phone at the poison center, are very comfortable with following these patients up with follow-up phone calls and keeping them at home. So what are the characteristics of a non-toxic exposure? Well, some of them are characteristics of the substance. Some of them are characteristics of the patient, and some of them are characteristics of the circumstances surrounding that ingestion. So this part of the talk is based on a chapter I wrote with Bob Hoffman on non-toxic exposures in this pediatric toxicology textbook. And that chapter is actually based a lot on an article by Howard Moffinson, who was actually the founder and the original director of the Long Island Poison Center, which no longer exists. Interestingly, he published the exact same article verbatim in 2 different journals. That I guess you used to be able to do that. Now you can't do that anymore. So these are the features that I think that you need to be able to say in order to say that something's non-toxic. So you need to know what it is, right? So if there's uncertainty about what the kid actually took, it's hard to say it's non-toxic if you're not sure what it even was, right? I think that is pretty intuitive. It shouldn't say caution, warning, or danger on the package. And we'll talk about where those words come from on packaging. It should be unintentional. If the kid was trying to commit suicide, then it doesn't matter what it is that they took, then that's not really a safe situation at home for them. It should be a single product. You should have a kind of reasonable assessment of the dose. Remember that concept of the dose response curve from Paracelsus. You should have an assessment of the route, because some things are toxic by one route and not by another. The child should be asymptomatic. If they're symptomatic, by definition, they have some type of toxicity. And you should have some available follow-up, right? If you have a 2-year-old that was exposed to some product and the 9-year-old that's watching them calls poison control or calls you, that's not really a safe situation, right? So that's you need to have a responsible adult available to have follow-up. So in terms of identifying the products, you want to have a careful history. For pharmaceutical products that aren't from the US, the Martindale's database, it can be useful. If you have Poisondex is one database that's available. That Martindale's is in there. If you don't have access to Martindale's, which I think both of our hospitals don't have anymore, when you call poison control, they can look it up for you. But that's a great database for pharmaceuticals. You want to try to get the name of the product, the manufacturer, the date of manufacturer, because sometimes the ingredients for the same product can change over time. And again, use the Poison Control Center to help you with this. Signal words. In 1960, the Federal Hazardous Substances Labeling Act required that certain things that are identified as toxic have these words, caution, warning, or danger on them. And in 1972, the Consumer Product Safety Act extended that to household products, not just kind of industrial products and chemicals. So if it has those words on it, it's because it's been recognized to be associated with toxicity. So by definition, that's something that you should bring that kid in for evaluation. It should be unintentional, right? So if it's a child that's under 6 months old, that's really for the most part before they start putting things in their mouth, and you really do have to worry about abuse neglect situation if the child has an exposure there, unless it's like a medication error by the parent. That's something the kid, it's not really consistent with the development of that child. So definitely be worried about kids under 6 months. When you have toddlers, that's kind of the peak age of pediatric exposures, right? Because they're crawling around and they explore the world by putting it in their mouth. And they don't typically take a lot of anything because if it doesn't taste good, they're probably not going to keep taking it, but they're going to kind of experiment with putting things in their mouths. And this group has the lowest fatality of all age groups because nobody's trying to harm them and they're not trying to harm themselves. And unless it's one of these one-pill killers, generally they do pretty well. But this is one of the big roles of the Poison Center in terms of identifying these ones that are probably going to be okay and preventing these unnecessary visits, and also remember to take that opportunity to educate the family. As soon as you get to kids that are over 6 years old, they're a lot more likely to be suicidal ingestions. They're not just kind of exploring their environment. In kids under 6 years old, 99% plus are unintentional. By the time you get to age 13, 46% are actually intentional with suicidal intent. So it should be a single product. So if a kid's taking all these different things, what's going on in that home? Is this a safe situation for them? So that's something that you have to ask yourself, unless there's a good explanation, right? And the classic case where maybe a couple of non-toxic products may not be so concerning is if it's like an art kit that has a bunch of different things. So the kid, was chewing on the eraser and also, took a nibble of the colored pencil and licked the paint. Well, okay, that's kind of reasonable. That's not necessarily an unsafe home just because they took a couple of things. They were playing with this product. Reliable dose. In general, take a worst case scenario. Assume that anything that isn't in the bottle is in the child, is kind of the worst case scenario, and then use that as a risk assessment. If they took that whole thing, everything that's missing, is that a dose you're worried about? Route of exposure, right? So crazy glue on the skin, not a big deal. Crazy glue in the mouth, not a big deal. Crazy glue in the eye, maybe that's a problem. Or a lot of hydrocarbons, right? Hydrocarbons on the skin, not a big problem. You swallow a hydrocarbon and you aspirate it, that's a big problem. So what is the route of exposure for the child? Symptoms. So obviously, if they have symptoms by definition, then it's not completely non-toxic. They have at least some low level toxicity. Sorry, I'm hitting this. I'm a New Yorker, I talk with my hands. But there are some things that are minimally toxic and they have predictable toxicity. So if a kid ingests some hand dishwashing soap and has a little bit of diarrhea after, well, that's to be expected, and you don't expect anything much worse to happen after that. They don't necessarily have to come to the hospital if they have some minor toxicity that is expected and is not expected to progress beyond that. Now, you should be able to have follow-up for that child, and we'll talk about that in a minute. So if nobody's available to take a call, that's a little bit different situation there. And this approach is validated by test data with toxic exposure surveillance system. So every time you call into the poison center, that goes into a national database of data that's published every year. And when patients are managed this way, they have good outcomes. Follow-up. There's got to be someone there that you can call and check up on the child and provide information about what should prompt another call. If there's not that situation, then they need further evaluation. And just remember that, you know, anytime that one of these cases come in, if they didn't call poison control and they do come to your ER and they took something that you're not worried about, remember that's your chance to say, you know what, you got away with it this time, but you really have to be careful about poison proofing your home and taking this as an opportunity for education to prevent the next time when potentially it could have been something worse, like one of those one pill killers. And anytime somebody calls the poison center about a child with a home call, poison proofing information gets sent to the home. Any questions about those before we get into these common household hazards? All right, so I'll talk a little bit about mothballs, about iron, about rat poison, about hydrocarbons. I'm going to skip the toxic alcohols because I almost always wind up giving, at least every 2 years, a lecture on toxic alcohols just by itself. So I think just for time, we're going to skip that one today. But these are all things that are in a lot of homes and are very common pediatric ingestions. So mothballs. What's in a mothball? Camphor is one thing. There's actually 3 different things it can be. So camphor is one of them. Naphthalene. Those are the 2 easiest. The third one is paradichlorobenzene. It's actually the most common one, though, paradichlorobenzene. So camphor, naphthalene, paradichlorobenzene, that's the order people always get them in because increasing difficulty. Camphor, we worry about because it causes seizures, right? It's a convulsant. It was in our one pill killer list. They happen right away. Usually the person comes in because they already seized. So this isn't delayed toxicity. If, like any toxic seizures, you're going to control it with GABA agonists, with benzos as your first line. Traditional anticonvulsants like phenytoin and things like that don't typically work for these types of seizures. Status epilepticus is rare, but it can happen. I think Stetz had a case like that in the Kings County ER a number of years ago. So rarely you can see status, but most of the time they have a seizure or a couple of seizures. Naphthalene itself is not toxic, but is metabolized to alpha naphthol. And this is potentially toxic in a group of susceptible patients with G6PD deficiency. In those patients, that they can get delayed hemolysis. So it gets metabolized, and then down the line, they get hemolysis over the next couple of days. Paradichlorobenzene is generally non-toxic in most situations. Patients will generally be asymptomatic. Only exception is massive chronic overdose. This is a New England Journal letter to the editor with the first 2 cases reported about this. Twin girls who had been ingesting a whole bunch of mothballs at home, and they developed what was described as a neurocutaneous syndrome. They get this ichthyotic rash, so kind of like this scaly reptilian skin kind of rash, and they get profound mental status changes. They get a leukencephalopathy. And since then, this has been a lot better developed. There's been more cases that have been presented. We had a case at Kings County in 2009. We wound up writing it up at the Poison Center. And so they get these kind of punched out white matter lesions, kind of looks like almost like prion disease. And they can really have profound and sometimes irreversible mental status changes. But that's, again, this guy had been eating a whole bunch of mothballs and smoking a whole bunch of mothballs, and he wound up in long-term care because he had irreversible deficits from his exposure. But that's not what you expect from a child who eats one mothball or licks a mothball or tastes a mothball. So the problem when you get a child with mothball ingestion is that a lot of the time, the packaging has been thrown out already, right? So the parents bought the mothballs, they dumped the mothballs out into their chest, into their dressers, and the packaging isn't available. And how do you tell them apart? They all look like mothballs and they kind of smell like mothballs. If you have them side by side, maybe they smell a little bit different. They maybe look a little bit different. The camphor ones maybe look a little greasier, like a little shinier than the others, but it's going to be pretty tough to tell them apart just by looking at one of them. So how do you tell them apart? Anyone have some ideas? So if you have a sample of the mothball, there are a couple of things you can do. First of all, about half the people in this room may recognize the smell of paradichlorobenzene because we encounter it a lot. The urinal cake is paradichlorobenzene. So maybe you might recognize it. I wouldn't rely on that 100% to hang my hat on. But if you have the mothball, you can potentially identify it. If you put the mothball in water and it floats, it's camphor. Right, camphor has low density, so if it floats in water, you know for sure it's camphor. If it sinks, it can either be the naphthalene or paradichlorobenzene. And one way to remember that is the paradichlorobenzene kind of stays at the bottom of the urinal; it doesn't float to the top. If it does sink and you happen to have some salt available, you can add salt until it's saturated, and then the naphthalene will start to float to the top. So naphthalene sinks in fresh water, will float in saturated salt water. If you don't have those things available or you don't feel like doing that, if it's one of the ones that sinks, you can X-ray the mothball, and paradichlorobenzene is radio opaque. Okay, so you can, if it floats, it's definitely camphor. If it sinks, you can try adding salt and see if it floats, or you can X-ray it. If it's radio opaque, it's paradichlorobenzene. If it's radiolucent, it's naphthalene. Or you can go on clinical grounds. Now, if you have the mothball, it's super fun to do these things, and for sure, I'm going to try to identify it. But you don't really have to do that, because if it's camphor, they probably seized already. And if they didn't, they're going to seize soon. And if they don't seize, they either didn't take it, maybe it was an exposure and not an ingestion, or they didn't take enough to harm themselves. If it's naphthalene and they're not G6PD deficient, you're not really worried about them. And if they do develop toxicity, it's going to be in a couple of days after they metabolize it and get that oxidative stress. So it's reasonable for those patients potentially to follow up with their pediatrician, check a urine, warn the parents that if they start to see really dark looking urine, that's a sign of hemolysis and they should be brought back. You don't need to do G6PD testing on these patients just for this. If they develop it, then that can be worked up later. And then again, if it's paradichlorobenzene, they're not expected to have symptoms unless it's some massive chronic exposure over a period of time. You had a question? You would have to expect that there's some degree that occurs because they're sublimating and that's why you're smelling it. But if there's still a physical mothball, then there is still potential for exposure there. Any other questions? All right, iron. So iron is a pretty common pediatric exposure, usually because of multivitamins that have iron in them, right? So most multivitamins, there's not enough of the vitamins in there for it to cause a problem unless someone's really going to town with a bunch of bottles of, and in particularly the fat soluble vitamins can start to be a problem in those cases. But for most multivitamins, the main thing we're worried about is the iron. And the other situation, and more commonly than multivitamins, is actually just iron supplements. Iron sulfate is probably the most common. Kind of looks like candy, doesn't really taste particularly good, but it's a common exposure because a lot of pregnant women wind up on iron. And so people, if they still have tablets left after they give birth, they may still have iron around. So a lot of households with children have iron in it. So it's just a common exposure. The iron is one of those toxins that if they're not vomiting, they probably didn't take enough to hurt themselves. There's only a few things like that. Things like caffeine and theophylline are also in that category. So if you get a kid with a potential iron exposure and they're not vomiting, you can feel pretty good that it's probably not a very significant ingestion. If you have a sense of that kind of worst case scenario for dosing, assume that all the tablets that aren't in the bottle are in the child. You can do a risk assessment. You can calculate the amount of elemental iron, and that depends on whether you're talking about iron sulfate, iron fumarate, or et cetera. It's almost always iron sulfate. I don't think I've ever seen a patient who took anything but iron sulfate, but you can look up the percent elemental iron in these other ones, count out how many milligrams it was, multiply it by the percent, and that'll tell you how much elemental iron it is. And if it's 15 to 20 mg per kg, that's a dose potentially that's going to be of concern. And then you could just measure the serum concentration. So serum concentration greater than 500 are people that were worried about 6 hours post-ingestion. If you know the dose and it's definitely over 15 mg per kg and the child is symptomatic, then that alone is reasonable to give antidote. If the kid is clinically sick, that is a good reason to give antidote. The people have looked at markers that usually can be associated with toxicity, and none of them are good enough to rule out toxicity. So things like white blood cell count and glucose are often abnormal in kids that are sick, but kids that are sick, and you can treat them based on that alone. So the fact that they're normal it's not sensitive enough to reassure you that they're going to be okay. If you are going to give deferoxamine, it's treatment. It's not going to be something that you give as a diagnostic test. People used to talk about giving a dose and then looking for the Van Rosé urine. Van Rosé meaning that kind of rosé wine color that the urine will get from the deferoxamine complexed with iron is a kind of pinkish color. So this isn't CSF. This is iron complex with deferoxamine in urine. But again, we don't look for that as a diagnostic test. We're just going to treat if we're going to use deferoxamine. Any questions about that before we go on to rat poison? Rat poison is a very common ingestion in New York City in particular. We have a lot of rats, and people don't like having rats in their home. So where did they put the rat poison? Where they saw the rat. Where do they see the rat? On the floor, along the baseboard, right? They put it in the same places that the kids go as they're crawling around. So it's really common for kids to get into these rat poisons. There have been almost anything in the world that is potentially lethal has been used as a rodenticide at some point in history. But most rodenticides that are sold in the US now, legally at least, are going to be cholecalciferol. That's basically vitamin D. The most common exposure is actually superwarfarins, and that was the most common one sold actually when I was a resident and when I was a tox fellow. If you went and bought Decon or any of the kind of common ones, it was almost always one of these superwarfarins, brodifacoum or bromadiolone. And all of these are basically warfarin, but they're really fat soluble. So they hang around for a long time and continue to anticoagulate the rat or the child. And they're, sometimes for months and months post-ingestion. And they started using superwarfarins because they were using warfarin and rats wound up developing a resistance to warfarin. And so they had to use a more extensive anticoagulation to kill the rats, because basically the rat lifestyle involves squeezing into these little spaces, and they almost always wind up bleeding to death if they get anticoagulated. So we'll talk a little bit more about that in a moment. Cholecalciferol, it's always been used on the subway tracks as the rat poison. Now it's in most home products. It's vitamin D. Rats die of hypercalcemia. If a child ate enough of it, there's no reason to think that wouldn't happen in a child, but human toxicity is extremely rare. It takes a lot of it, and most kids don't eat that much of it. Superwarfarins were banned for use in products that are designed for the home in 2011. It has a long duration of action, months. Management, if you have a patient with a superwarfarin ingestion, you can think about GI decontamination. I wouldn't, be too aggressive with it, but if the parent can get the child to take some activated charcoal, maybe it'll potentially prevent toxicity. And really what you want to do is check a coagulation profile at 48 hours. You can check a baseline in case they've been doing it for a while and this is just the first time you caught them. But the problem is that you don't expect them to get anticoagulated right away. Just like for warfarin, it takes time to deplete your vitamin K dependent cofactors in order to get anticoagulated. It takes a couple of days. So they're going to need to follow up with their pediatrician to get coag sent at 48 hours to see if they're going to become anticoagulated. Now, if their INR is elevated, then they're going to need long-term treatment with vitamin K and often high doses. Now, you might think, why not just give vitamin K and prevent them from getting anticoagulated? And the problem is, if it's a super long-acting warfarin, then that would be fine if it was just warfarin. But if it's one of super warfarins, they're going to need ongoing anticoagulation for a while. And then if you gave them vitamin K up front, how do you know that their 48-hour coags are normal because you treated them, or if they just didn't take it? So you want to be able to identify the people who actually need it for that extensive period. And that's a very tiny fraction of the kids that are found with it. Right, because and again, this is part of the problem with conflation in the literature with exposure versus ingestion. A lot of kids are found next to rat poison. Very few of them actually eat and ingest a consequential amount of it. But if they do, you have every reason to expect that they're going to get anticoagulated and are going to run into trouble. So you want to identify that tiny fraction of patients that's going to need long-term treatment, and you do that by checking the 48-hour coags. Now, you'd say, wow, this has been banned since 2011. Why are you still talking about it? Right? Well, this is the 2022 NPDS report. This is when I talked before about the toxic exposure surveillance system, when you call into the poison center and they compile all that data. The 2022 is the most recent one that's available. That was published in December 2023. So, 8 months ago. And if you look at the rodenticides that are called into the poison center, the most common one is still long-acting anticoagulants, and people keep things around for a long time, and a lot of stores keep things around for a long time, even though they're not supposed to still sell them. So this is still the most common one that gets reported. Now, there's bias there, right? Because if it's one of these, it's more likely to get called into the poison center. And who knows how accurate it is what it gets reported as, right? Somebody calls in a case and they say it's decon, and somebody on the other ends of the line that's working at a poison center puts in anticoagulant, but it's not like they're getting blood levels of these things and actually confirming that that's what it was. So, there's a lot of potential confounders here, but it's still a relevant thing to think about for sure in kids that potentially ate a rodenticide in the home. Next thing we're going to talk about are hydrocarbons, and there's a ton of hydrocarbons that are potentially in the home. This is a pretty big list of things. Obviously you don't have to memorize all of these, but basically all of the things that are chains of carbon with hydrogen and sometimes with functional groups that are added onto it are hydrocarbons. And in general, hydrocarbon toxicity is multi-organ system toxicity. The most common thing that we worry about generically with hydrocarbon ingestions in the home is aspiration pneumonitis, because those hydrocarbons dissolve the surfactant and you can get really horrendous ARDS-like picture. And I'll show you a picture of that. You can get neurotoxicity, you can get cardiac toxicity with some specific hydrocarbons. GI irritation is pretty common after ingestion, and that's not that consequential. The aspiration pneumonitis is the biggest thing that we worry about. And just for time, I'm not going to ask you to name the 5 V's of hydrocarbon aspiration, but these are features that make aspiration more likely for a given hydrocarbon, and some of them are properties of the substance, and some are properties of the ingestion. So volume, if you ingest more, you're more likely to aspirate it. Vomiting. If you vomit it, you have another opportunity to aspirate it. So vomiting is an increased risk of aspiration. Viscosity. Which do you think is better, more viscous or less viscous, or which is more likely to be aspirated? Less, right? Yeah. So, right. Think about elderly patients. We add thickeners to their feeds to prevent aspiration. So things that are thin are easier to aspirate. Volatility. So the propensity of a hydrocarbon to form a gas. Things that are more volatile are easier to aspirate. And then this last one is kind of fudging it to get the V, but surface tension or van der Waals force, that's the tendency of something to stick to itself, right? So if you think about the way that water beads on the surface of a waxed car, it really likes to stick to itself, right? So as you swallow some water, as it hits the back of your palate and makes a turn down past the epiglottis and into your esophagus, the rest of it kind of sticks to it and follows it as it goes down. Whereas things that have low surface tension tend to break up into tiny droplets as they hit a surface and are much easier to aspirate. So this is what aspiration pneumonitis can look like after ingestion of a hydrocarbon. It can be complete whiteout of both lungs. I've had a patient like that before. The thing that's really important about this is that it can lag. An initial X-ray, if you get it when the patient hits the door, it may look normal. Most patients are going to have some type of episode of gagging or coughing, and they'll have some kinds of symptoms, usually within the first half hour. Tachypnea is really common, and absence of tachypnea has a pretty decent negative predictive value, but not good enough to rule it out. And really the most important thing, and this is very commonly on the EM boards and very commonly on the pediatric and pediatric EM boards, but you got to get that delayed chest X-ray, 4 to 6 hours post-ingestion, to make sure that you're not having a delayed finding. Just going to skip this. Cardiac toxicity is something that we can see with certain halogenated hydrocarbons. So hydrocarbons that have functional groups of chlorine or fluorine or bromine or iodine that are added to them. They tend to block potassium rectifying current and cause prolonged QT, and that can predispose you to getting dysrhythmia, specifically torsade de plainte. Right, so you get that prolonged QT, that's a substrate, and when you get a stimulus on top of that substrate, then you can get an R on T, and that triggers torsade. And this has a specific name in kids that are abusing halogenated hydrocarbons as a recreational drug, right? So when kids that are like huffing or sniffing like propellant in an aerosol can for paint, those tend to be halogenated hydrocarbons, and it's called sudden sniffing death, right? So the kid is abusing that halogenated hydrocarbon, they're getting that prolonged QT, that substrate, maybe they're in the school bathroom using it, and then an authority figure walks in, startles them, they get up to run away, and they drop dead because that catecholamine release on top of the substrate of prolonged QT can trigger torsade. As I said, I'm going to skip the alcohols to keep us on time. I promise you will get a complete lecture on toxic alcohols. And I'll go to this summary. So for a few toxins, one pill is potentially deadly in a child. Some exposures are safe enough that we can consider them as non-toxic, and they don't require a hospital evaluation. I don't expect anybody here to necessarily do that over the phone, but recognize that poison control will certainly do that, and you can identify it as toxic, as non-toxic, once you've seen the patient for sure. Remember that you can distinguish mothballs with salt and water and with an X-ray, but you don't really have to, because if the kid looks good after a reasonable period of observation and you don't know what kind of mothball it is, you can have them follow up with their pediatrician in 2 days and see if they have evidence of hemolysis. If you have an iron ingestion, try to do a risk assessment. If you know how much it potentially could be and you know what type it is, then you can see if it's enough to harm the kid. If you don't know that, then you're going to check a level, and a level over 500 is what we worry about. And if they look sick, then potentially they need treatment regardless. For rat poison ingestion, they need a 48-hour INR. For hydrocarbons, remember, you can get that aspiration pneumonitis, and you need the delayed chest X-ray. Halogenated hydrocarbons cause dysrhythmias, and we didn't talk about the toxic alcohol part. Any questions? Dr. Sijani.
Question would be like, if that was a group with volume and they make products and give out now, is it wise to say, instead of volume control numbers, call them? If they say come in, then do that.
I think that's totally reasonable. Yeah, I think if somebody calls and you're not comfortable telling them to not come to the ER, telling them to call poison control and discuss it with them about advice about whether to come to the ER is a reasonable thing, for sure. I'm going to send the PDF version of this to for distribution for you guys. I have an appendix about some toxicity of some household products that are potentially a little bit more obscure, and some common non-toxic products.